All right, let's jump right in. Today, we're tackling one of the most important topics for any pharmacist, the chronic complications of diabetes mellitus. If you're getting ready for the PEBC exam, you've got to know this stuff inside and out. We're going to dig deep into the guidelines and the therapeutic choices that can make a huge difference, both for your patients and on your exam.
Okay, so here's the plan. We're going to start with the big picture. The real-world impact of diabetes and what our goals as clinicians really are. Then we'll break down each of the major complications, one by one. We'll cover everything from the eyes and kidneys to nerve damage, and then zoom out to the big stuff, cardiovascular protection, heart failure, and absolutely critical foot care.
First things first, let's really frame the problem. It's so important to understand the massive scale of diabetes in Canada and why tackling these complications is, frankly, a massive public health priority. Get this, more than 3 million Canadians are diagnosed with diabetes, and that number? It's still going up. This isn't just some abstract statistic. It's a huge population of people who are at risk for some really serious long-term health problems.
And believe me, the stakes are incredibly high. We are talking about the #1 cause of new blindness in working-age adults, the leading reason people end up with kidney failure needing dialysis, and the main cause of amputations that aren't from some kind of accident or trauma. It really just drives home the devastating power of uncontrolled diabetes.
Now, this slide shows a concept that is absolutely vital to understand: the cardiovascular burden. Basically, having diabetes is like fast-forwarding the clock on your heart and blood vessels. It ages your cardiovascular system by about 10 to 15 years. So think about it. A 50-year-old with diabetes has the same cardiovascular risk as someone who's 60 or 65. That's a powerful way to think about the increased risk of heart attacks and strokes. So that brings us to our goals. And you can see it's about way more than just hitting a target blood sugar number. We are actively trying to protect the eyes, the kidneys, the nerves, and the heart. And you just can't do that without a real partnership with the patient. That means regular follow-ups, clear education, and working together to hit those treatment targets.
Before we even think about a prescription pad, we have to talk about lifestyle. It's the foundation of everything, and the recommendations are really specific. We're talking a minimum of 150 minutes of aerobic exercise a week, plus a couple of resistance training sessions. For nutrition, it's about following Canada's food guide, with a focus on weight loss if it's needed. And smoking cessation? That's just non-negotiable. We've also got to counsel patients on alcohol. Look, moderate drinking is usually okay, but it's so important to talk about the risks, especially the risk of delayed hypoglycemia for anyone on insulin or a secretagogue. Plus, it can be a problem with metformin and lactic acidosis, so making sure patients understand these limits is just a key part of keeping them safe.
Okay, let's move on to our first specific complication: diabetic retinopathy. Like we said, it's the most common reason for new blindness in working-age adults, so you can see why catching it and managing it early is, well, it's everything.
Now, this is really important and a classic exam topic. Notice how the screening schedules are different. For someone with type 1, we wait 5 years after they're diagnosed. But for type 2, we screen right away, at diagnosis. Why? Because a lot of people have had type 2 for years without even knowing it. And pregnancy? That's a whole other ballgame, with a much more intense schedule. These are definitely high-yield facts to remember.
And there are a couple of special situations you need to be aware of. It's a little counterintuitive, but if you rapidly get someone's blood sugar under control with intensive insulin, it can actually make their retinopathy worse for a short time. Also, the SUSTAIN-6 trial raised a flag about semaglutide in patients who already have retinopathy, so they need closer monitoring when you start that medication.
So how do we treat this? Well, it's a multi-pronged attack. It always starts with the basics: tight control of blood sugar and blood pressure. Then you've got some more specific tools. Fenofibrate, interestingly enough, has been shown to slow down retinopathy, and that's separate from its effects on lipids. Then for more advanced disease, we've got direct injections into the eye of anti-VEGF agents. They're first line now for macular edema, with steroids as a backup plan.
All right, moving on to the next major complication: chronic kidney disease, or CKD. This is a huge one. Up to half of all people with diabetes will show some signs of kidney damage during their lifetime. So yeah, it's incredibly common and incredibly serious. So how do we actually find out if someone has CKD? Well, the process is very clear and structured. We screen every year using 2 key tests: a urine test called an albumin to creatinine ratio, or ACR, and a blood test for the estimated glomerular filtration rate, the eGFR. Just like with the eyes, for type 2, we start right at diagnosis. For type 1, we wait 5 years. And to make a formal diagnosis, the problem has to be persistent.
That means we need to see abnormal results on at least 2 out of 3 tests over a 3-month period.
Okay, this is such a critical point for real-world practice and for your exams. ACE inhibitors and ARBs are amazing at slowing down kidney disease. But, and this is a big but, only for patients who already have high blood pressure or protein in their urine, that is, albuminuria. They are not recommended just to prevent kidney problems in someone with normal blood pressure and a normal ACR.
And here is a major warning. You never ever use 2 drugs that block the RAS system together. So that means no combining an ACE inhibitor with an ARB. It just doesn't add any benefit, and it seriously increases the risk of acute kidney injury and dangerously high potassium levels. It's a huge contraindication. You know, the world of diabetes drugs has been completely turned upside down by these newer agents that have proven kidney benefits. SGLT2 inhibitors are not recommended specifically to slow down the progression of nephropathy in people with type 2 diabetes and CKD. And while the GLP-1 agonists also show some renal benefits, their main effect seems to be reducing albuminuria. The SGLT2s, on the other hand, have shown they can reduce hard outcomes, like progression to end-stage kidney disease.
And this brings us to probably one of the most important pieces of counseling we can give our patients, especially those with kidney issues, what to do on sick days.
The SADMANS mnemonic is just a fantastic tool for this. So here's the deal. When a patient is sick, maybe throwing up or has diarrhea, they can get dehydrated. That reduces blood flow to the kidneys. And when that happens, these specific medications can suddenly become dangerous. So the advice is to temporarily hold them to prevent acute kidney injury. It's our job to make sure patients know about this and know exactly when to stop and when to restart their meds.
All right, let's talk about something that so many patients experience, diabetic neuropathy. It's incredibly common. We're talking up to half of all people with diabetes within 10 years of diagnosis. This nerve damage is the main reason people develop foot ulcers, which can tragically lead to amputations.
When that neuropathy becomes painful, our go-to first-line agents are certain anticonvulsants and antidepressants. But here's a huge counseling point. We have to set realistic expectations. It's really important to be upfront with patients and tell them that complete pain relief is very rare. A 30 to 50% reduction in pain, that's what we consider a win. Opioids are way down the list, reserved only for very specific cases because of all the risks involved.
Okay, so we've been talking a lot about the small blood vessels, the microvascular complications in the eyes and kidneys. Now let's zoom out and talk about the big ones, the macrovascular complications involving the heart and the major arteries. Because diabetes puts cardiovascular disease into overdrive, we have to be proactive. A solid vascular protection plan is just standard of care.
The role of aspirin. This is a topic that causes so much confusion. So let's make it super clear. For secondary prevention, meaning in a patient who has already had a heart attack or stroke, yes, aspirin is essential. But for primary prevention, in someone who hasn't had an event, it is not routinely recommended anymore. The risk of bleeding just outweighs any small benefit.
So, who gets these other protective therapies? Well, according to Diabetes Canada, pretty much everyone with diabetes over the age of 40 should be on a statin, or even younger if they have other risk factors. As for an ACE inhibitor or an ARB, they're recommended for anyone with existing cardiovascular disease, anyone over 55 with another risk factor, or anyone who has those microvascular complications we just talked about.
And this is where things have gotten really exciting in the last few years. This is a total game changer. We no longer pick diabetes meds just to lower blood sugar. Now we pick them for their proven cardiovascular benefits. So if you have a patient with type 2 diabetes and known heart disease, the guidelines are clear. You should be using an agent from either the SGLT2 inhibitor or the GLP-1 agonist class that has been proven to reduce cardiovascular events.
Okay, to wrap things up, let's hit 2 more really important areas. First is heart failure, a condition where our choice of diabetes medication can either really help or really harm. And second, we'll talk about foot care, where simple, preventative steps can literally save a person's limb.
What's amazing about this is how clear the recommendations have become. SGLT2 inhibitors are now recommended for patients with a certain type of heart failure, and get this, even if they don't have diabetes. That's because they are so good at reducing hospitalizations. On the flip side, the thiazolidine diones, or TZDs, are a big no-no. They're contraindicated because they cause fluid retention. And we have to be cautious with the DPP-4 inhibitors, especially soxagliptin, which showed a potential for harm.
Foot ulcers are just a devastating complication, but they don't just appear out of nowhere. They're usually the result of a perfect storm of problems: loss of feeling from neuropathy, poor blood flow from peripheral artery disease, and changes in the foot shape that create pressure spots. And the single biggest predictor of a future ulcer? Having had one before.
So the big take-home message for foot care can be summed up in one word: prevention. It is all about patient education. Teaching every single patient with diabetes how to check their own feet every single day for any cuts, blisters, or redness, that is the most effective thing we can do to stop a small problem from turning into a limb-threatening emergency.
So, to wrap this all up, I want to leave you with a practical question to think about. For the very next patient with diabetes that you see in your practice, which one of these crucial screening tests, eyes, kidneys, or feet, is most likely to be overdue? The truth is, it could be any of them. Our job is to be systematic, to make sure that regular screening happens on schedule every single time. That is how we prevent these complications. I really hope this explainer was helpful. Thanks for watching.